Welcome. Thank you everyone for joining us today. My co-panelists and I are really excited to talk to you about the Congenital Heart Valve Program here at Boston Children's Hospital. Just to give you a sense, so on the panel we have Dr. Christopher Baird. He's a cardiothoracic surgeon and the director of our Congenital Heart Valve Program. We have Dr. Jerry Marks, who is a consummate pediatric cardiologist and an echocardiographer. Dr. Peter Hammer, who's a research scientist with his PhD in bioengineering. And my name is Rena Ghosh, and I am a pediatric cardiologist working within the Department of Cardiac Surgery. So today we're going to touch upon a few things about our program, namely who the patient population is, who's getting valve surgery. Number two, what's the difference between valve repair and valve replacement? And then also what makes our program unique in how we take care of these children. And then I know also some of you have written in some questions ahead of time, and so we'll make sure to get to as many of those as we can at the end. So Dr. Baird, I was wondering if you could start us off by sort of describing our patient population, who needs valve surgery, and how we decide when they need it.
Sure. So at the Congenital Heart Valve Center here at Boston Children's, there's a number of aspects to the program as we're going to go through today. But importantly, we have to think about what that means and what that program's emphasis is. And here at Boston Children's, our approach with all the valves of the heart, basically, if you think about the aortic valve, the pulmonary valve, the mitral and tricuspid valve, and then you can throw a few other valves in there like truncal valves and complete AV canal valves, we like to look at each of those valves individually. And there's really different algorithms or approaches to all of those valves. And some of them have better opportunities for repair or reconstruction, and others may be better suited for replacement. And quite frankly, they're different replacements. And the outcomes are different based on the different types of replacements. So I think what we tend to do is individualize it, and we look at the imaging very specifically. It starts with an echocardiogram and the cardiologist clinical assessment of the patient, and then we go from there. And then I think Dr. Marks can talk a little bit about from their perspective, how is our approach different here at Children's Hospital of Boston with regards to cardiology and the assessment and preparing those patients to come to surgery?
Dr. Marks, do you mind commenting a bit on that? And then also on valve repair versus replacement from a cardiologist perspective?
Sure, Rena. Good morning. It is a privilege for me to be part of this podcast and to share with you the efforts of our heart valve surgery team at Children's. Certainly the pivotal question is, why do we do valve repairs? I can provide an experience of taking care of patients over several decades who have had valve repairs dating back to our early experience at Children's, even in the early 1980s. So as Chris alluded to, valve surgery is undertaken when, after very careful evaluation, the decision is that the hemodynamic effects on the heart, cardiovascular system, and patient's health, we believe that surgery is deemed necessary. It is essential to understand that each patient and each valve is very different, and so the individualized evaluation, surgical planning, and surgical repair is essential. So the important and perhaps critical issue for valve repair is that when most, if not all, the valve tissue is preserved, the valve can grow with the patient, obviously an essential issue for pediatric patients. Even if eventually a prosthetic valve is necessary, the older and bigger the patient is, the easier to place a larger prosthetic valve in the hopes that the patient doesn't outgrow the valve. Just as an example, just this week, a 14-year-old girl came back to Children's Hospital for evaluation of her mitral valve, which has shown signs of deterioration. She had a valve repaired by Dr. Baird when she was 4 months of age and has experienced excellent growth and development since then. Obviously, a replacement at 4 months of age, even if possible, would have been fraught with reoperations. There are even times when the patient is too small, or even the portion of the heart where the valve presides is too small to allow a prosthetic valve to be placed. And so individualized repair is undertaken. We always consider and weigh the risks of valve repair versus replacement. We know that certain biological valves, like a tissue valve from a pig, cow, or even human, often have a very short longevity in younger patients. Mechanical valves can have a much longer duration of good valve mechanics, but to date require a blood thinner or anticoagulant. Of course, this has obvious implications for the teenager who wants to play competitive sports, or a younger child who may accidentally fall, or even for a woman considering pregnancy. Obviously, all of us want the valve repair to last as long as possible with good overall mechanics. I and my colleagues will subsequently demonstrate in this podcast how we are applying an intense collaborative effort with increasing advances in imaging, mechanical and engineering processing of valve anatomy and function, and creating, as Chris alluded to, the individualized, more precise pre-surgical strategy, along with the surgical expertise to achieve the goal of optimal surgical repairs. So with this, I hope this is the lead-in for some of the more precise individual analysis that we do.
Yeah, and Dr. Marks, you touched upon one of the big challenges, obviously, being patient size, especially for these very, small patients, as the one you just mentioned, the 14-year-old who had their valve repaired by Dr. Baird early on. Dr. Baird and Dr. Hammer, could you touch upon some of the other challenges as well, particularly those related to operating on a heart that's stopped, that's on bypass, versus the imaging that we see, which is done when the patient's awake?
Yeah, I think I'll briefly start and then let Dr. Hammer kind of go into it a little bit more in detail. I think importantly for the surgeon, we need a roadmap. And just like you need a map if you're going somewhere to know exactly where to go, ideally we have a roadmap that tells us exactly where to go in the heart and exactly what to do to make that valve function. It's really that simple. And there are several different tools that can do that. And historically, echocardiogram, and still is, the mainstay of that in terms of looking at valve function and heart function. But there are other tools now that can be utilized to really help us understand how the valve works and functions and gives us ideas on how we can make that valve better. So we turn to the engineering team to help us figure that out, because working on a flaccid heart when a heart stopped is very different than a heart that's pumping and moving. And we have to make sure those tissues and valves, the leaflets, come together appropriately, because if they don't, even if they're just a little bit off in some way, it can lead to regurgitation. So, Dr. Hammer, do you want to comment a little bit on the type of imaging and modeling that you guys have been able to develop to help coordinate these efforts?
Yeah, thanks, Dr. Baird. I can also want to make one point that one of the challenges with valve repair is that every patient is different and every valve is different. So it's not like a surgeon did one yesterday and today's valve will be the same because it's a mitral valve and it needs to be fixed. Every valve is different, and it's different because patients are all born with different anatomy. And then importantly, if they've had a prior intervention, a catheterization to balloon dilate a valve, or even a prior surgery where there's cutting and sewing and patching done, that by the time they arrive to get valve surgery, that's really a one-off. There is no other patient with a valve exactly like that one. So you can't rely solely on experience to get it exactly right. So that's where the modeling and the detailed imaging comes into play. And maybe I can share a screen to talk about what I mean by 3D models and what these what these models enable. So this is just this is a slide that describes when we talk about 3D models. This is what we're talking about in the context of these valves in these patients. We take patient imaging like CT scans and MRI scans, and we turn them. We have a team of engineers that make these 3D models out of those, out of that sort of black and white stack of images from the CT or MRI scans. And what these 3D models are is they're surface models on the computer of all the structures of the heart separately identified and separately colored. And this really gives us a substrate to be able to go through and make measurements, to display, to zoom in, to make cut planes, and to do things with the patient anatomy in this state that you really have a hard time doing from the raw imaging itself. So with these 3D models, we use them for a variety of things. We use them for intraoperative guidance, for quantitative surgical planning, and in some cases for blood flow simulation. The part that we're talking about with the valve program is this quantitative surgical planning, taking the 3D model, making measurements of structures of the valves, details of the valve, and using that to help plan, both to examine what's wrong with the valve, how it's out of proportion, and then how it needs to be fixed surgically to put it in proportion to a normal valve.
Sorry, Dr. Hammer, I'm just going to stop you for 1 second. It seems like some people on the webinar may not be able to see the slide. Are you able to just share it again? Like
Sure.
unshare and then share?
Yeah.
Thank you.
Is this better now? I'll proceed it if it is, and if it's not, people can
I can see it.
I can see it.
Okay. So as I was starting to say, the models enable us to make measurements from valve structures and use those in very precise and proscriptive ways to plan the repair and details of the repair. And the models are also a way to, I think, to help illustrate the point that Dr. Ghosh was making about the intraoperative state. When these surgeries are performed, the heart is stopped, it's emptied of blood, and things are in a very non-natural, empty and unpressurized state. The video on the left here shows a physiologic view of these valves, where when the valve is functioning and operating in the patient. Sorry, this is video. Is this video going? I have to do this in full screen mode. I'm sorry. Hopefully this video is showing for you. On the left, there's a video of one of these digital models rotating around. We just cut it and look. Now we're looking at the top of the aortic valve, and you can see this is done in the patient in the CT scanner when the heart's beating. So you're seeing the structures as they appear in the body with everything pressurized and stretched to its normal states. That's not the view the surgeon gets during the procedure, where they are looking at the top of the valve like this, but everything is contracted and collapsed and not under pressure. So by being able to look at the valve in this state, the 3D model enables us to look at structures in their loaded conditions, get their dimensions and proportions, and then relate those back to what the surgeon sees intraoperatively. So it's that discrepancy between the intraoperative state of the valve and the physiologic state that really underlies part of the challenges for the surgeon, trying to make that leap in their imagination between what they see intraoperatively and the state the valve is in when it's in the heart and beating.
And so, to your point about the imaging that we're using preoperatively, to give our patients and families a sense of this child undergoing a surgery, so once the medical team and the family together have made a decision that the child is going to go to surgery, we obtain these studies that we've been discussing. So obviously an echocardiogram, like Dr. Barrett had mentioned, and then cardiac CT or an MRI to create those models that Dr. Hammer was just showing. I know a question came into the chat asking about if these models can be made by something other than cardiac MRI, for example, if a patient has pacing wires. And yes, we can use cardiac CT, so we can use either. And we do our studies at Boston Children's Hospital. They're specifically planned to look at the patient's valve while it's beating. So just so you know, there may be times when your child has had a study that was done at another hospital, another institution, and sometimes we may ask to repeat that study so that we can specifically take a look how it's moving during the cardiac cycle. So I'm just going to share screen as well to build on what Dr. Hammer was talking about. Oops. Here. So this is an example of a high spatial resolution cardiac CT, and we're doing a 4D evaluation of the mitral valve. So we did a cardiac CT that looked at your child's valves in 3 planes of space, and then also looking at it in the 4th dimension across time. We can take that cardiac CT and put it into imaging software that really allows our team and the surgeons to take a look inside the child's heart to get a sense of what those abnormalities are and how they may be addressed in the OR. We can then take this imaging one step further, and as Dr. Hammer was showing, create digital models of that patient-specific valve in both the open position and the closed position. And in doing this, we really allow the surgeons to drill down on what components of the valve need to be repaired and how they might best do that. And going back to the point about what the heart looks like at the time that the patient got the scan, where the heart is beating and maybe your child was awake for the scan versus in the OR when the heart is stopped, we take these images and based on the measurements or the repair that the surgeon thinks they're going to undertake in the OR, we can make those measurements for them ahead of time on the quote unquote beating heart to give them a sense of what those numbers should be when they go into the OR. Dr. Hammer, I don't know if you'd like to comment a bit on some of these techniques and how they're used in aortic valve surgery.
Yeah, just briefly, this is a lot of detail and a lot of numbers, but the bottom line is we know what the proportions of an aortic valve, and on the left, all 3 of these panels show variants of, different ways of looking at an aortic valve. We know what proportions characterize a working aortic valve, and then we know when those proportions fall out of these typical ranges, the valve won't work normally. And by not working normally, we mean it's either going to leak, have some backwards regurgitation, or it's not going to open fully, and it's going to cause restriction in the ventricle to work too hard to get the blood out. So we can use the model to make the measurements of different structures of the valve, the width of the leaflets, the height of them, the symmetry of the valve, and other features. And then we can see, are they falling in normal proportions where we expect the valve to work well, or are they falling outside those ranges? And then we can look at dimensions that are falling outside of the ranges that we expect, and we can say, what should they be to make a well-functioning valve? So we have these sort of conceptual models of what a normal proportion valve looks like. We have the dimensions of the actual valve, and then we can then make a plan, really a design for how to change different features to make the valve work well. And we have a simple computer model on the right there that sort of abstracts some of these features of the valve and lets you pull things around and drag them and move them in real time and see, if I change this, how will that affect how much the valve opens, how well it closes, and functional descriptors like this.
I think this, if I may comment, this is a really critical piece from a surgeon's perspective. For us to be able to understand and know exactly what we need or should do before going in, rather than going in, opening the valve, looking at it, and trying to figure it out, this is tremendously helpful. And for several reasons. One, to the individual surgeon, it gives much more confidence in their ability to fix the valve. But secondarily, it gives options for that surgeon to consult and discuss this valve with others who may have a different perspective or different experiences in order to get the best outcome for this patient. So in reality, it's not only the single surgeon that you're getting the opinion from, but you're getting it from a whole slew of other folks that are helping understand the valve, including cardiologists and engineers and other surgeons. So I think this is a really important detail that really differentiates the way we think about valve disease here at Children's Hospital. You're not necessarily just being labeled on echocardiogram, you have a lot of aortic regurgitation, go to Surgeon X and repair the valve. It's far beyond that. So when you get that diagnosis here at Children's, you send and ask us for an opinion about it. We step back and begin to ask the questions. All right, how can we understand this valve better? And let's solicit opinions on what may or may not be the best option for this child. And that's part of the process, which leads a little bit to one of the questions that was asked in terms of timing, and when is a good time to send your child's information to be reviewed. And I would say the earlier the better. Even if the cardiologist is saying, we think you don't need surgery right now, many, many times that's based on the experience at their institution of not having the ability to identify very specifics about the valve or even the valve repair experience. So they're giving you that based on that. So I think our approach may be different. And on the other hand, we may be able to suggest other tests or other studies that may help us give a better prediction of how the patient may do, whether you operate now or later. So I think those are really important, which ties into that question. When should you send your information for an opinion about the valve? And I would say sooner rather than later. Dr. Marks, do you have a comment on that from a cardiology perspective?
Yeah, Chris, it's a great point. You know, as a team, if I get the information, I always go to our team. And first of all, we do evaluate, you know, how much is this valve repair affecting, or this abnormal valve affecting the heart, and how much is it affecting the infant, child, or even adolescent in their growth and development and ability to get around. We oftentimes will do want to get results of an exercise test or even a catheterization for hemodynamics. But we always like to evaluate that patient earlier than later, especially for the instance of valve repair, because if you can do a valve repair early and do it and the results are good, then it's different than having to put in a prosthetic valve in a very young child or even an adolescent. So the ability to potentially repair the valve, I don't want to say essentially changes the threshold, but it does allow us to really consider being able to operate earlier in life rather than later. We often feel that if we can even repair the valve early before the valve starts to become more abnormal, it may even obviate or not have to end up having to replace the valve. So I certainly agree with Chris, the earlier than better.
One of the points that Dr. Marks and Dr. Baird that you were alluding to is that this really is a multidisciplinary effort. We are a very collaborative team, and you know, each of us has a different component, but all coming together and offering different viewpoints to address your child's valve disease. So perhaps maybe Dr. Hammer, could you talk a little bit about who is on our congenital heart valve team and all that goes together?
Sure, I can describe from it's a collection of cardiologists and cardiac surgeons and engineers. From the engineering side, I think that's the unusual component. So I'll talk about that part of the team. It's myself and another engineer, Lauren Marshall, who's not on the call, really lead the efforts to make these 3D models and then use them in a way to plan and describe the patient's valve and how to intervene on that valve, at least using models and dimensions and proportions. This is largely for aortic valves. The mitral valve effort is really, again, led by the engineering team, but largely led by Dr. Ghosh, by Rena Ghosh, our host. And it's the 3D models that are used to do both the aortic valve and the mitral valve models are built by a team of engineers. And this was a question asked in the chat, like who makes these 3D models? Are they done by a partnership with a device company or software company? And they're not, they're done internally. So we have a team of engineers, about 6 engineers that are dedicated to taking the medical images, bringing them into specialized software, making these digital 3D models, and in some cases using other computer drafting and design tools to modify those and to do virtual surgeries and things like this. So it's really a team effort. And from the engineering side, it's a group of professional engineers, not grad students and not not folks at the university across town, but people in the department, trained engineers working really full time at making these digital models and then deploying them and using them in ways to help assist in these surgeries.
I think it might be worth adding, there's a couple of other parts of the team that may not be so obvious that are, in my mind, critically valuable. For example, the ICU team postoperatively, after the operation, where do you go? You go to the ICU and you're managed by a very subspecialized group of doctors, ICU doctors and cardiologists. And it's so critical, and it may seem basic, but for example, blood pressure management or monitoring, if you don't manage that very precisely, the valve repair can fall apart. And if the valve repair falls apart, then obviously that leans towards another potential repair and or replacement in the very short term. So we find that very, very important to have these team members. We're just starting a new program now to have an outpatient blood pressure monitoring program for very specifically valve patients. We've just come up with a strategy to try to send blood pressure monitoring home and monitor it digitally and get back to the primary cardiologist to help manage and make sure blood pressure is well managed in valve patients. That's just a couple of examples of how our team's really expanded. And it's not just the obvious cardiac surgeon and cardiologists involved, but there are many, many other people to the team.
That's a really point. I'm grateful that you made sure to acknowledge our entire, the entire team and everybody who's taking care of these patients. I know that there are a lot of questions coming into the chat and some that had been submitted ahead of time. One of the questions that came in was about accidental cutting of the conduction system during the valve surgery. This was a separate webinar topic, so there's a lot to cover today. This was a separate webinar topic. I'm hoping maybe that our hosts are able to send the link out about that, but just so that for any families who are wondering about that question, we use 3D models to help map out the conduction system during surgery. But there is a whole separate webinar about that topic. So I just wanted to mention that. A question that's come in several times, Dr. Baird, maybe you can comment on this. How many repairs can realistically be undertaken on a mitral valve or aortic valve before requiring replacement?
Yeah, good question. And just one comment on the conduction. That work really started with in and around the mitral and tricuspid valve. And just recently, as early as about 10 days ago, we did the second patient with beating heart aortic valve conduction mapping. And so now we're trying to apply that technology to work on the aortic valve to avoid conduction. So I just wanted to highlight the fact that we're always trying to figure out how best to optimize the operation to avoid morbidity. So I think that is very critical and important. And very specifically, to comment on how many repairs is too many, that's very individualized. I can tell you, and we published this maybe 10 years ago, mitral valve re-repair in general has less morbidity and mortality than mitral valve replacement in younger patients. And so what that means is that even if you have to repair the valve once, twice, maybe 3 times, then sometimes that's a better option. Now, on the flip side, what you need to know and what you want is the experienced, the clinicians taking care of you to make the decision that when is repair enough and you need to go towards replacement. And I think that is a really important question. And I think the experience here over the years, and Dr. Marks can tell you, it's not always repair. He has many patients he follows that have had a mitral valve replacement with a mechanical mitral valve, let's say, in the right patient for, I don't know, 10, 15, maybe even 20 years that he reminds me of. So it's not just about repair, but we're trying to also optimize what is best for your child very specifically.
If I can just make quick points about the conduction, one of the things that's very new at our center and really nationwide and worldwide is that the surgeons can now map the conduction system of the heart before doing the surgery. And Chris, if I may say, we have very good evidence that shows that our incidence of developing permanent injury to the conduction system has markedly decreased since our ability to evaluate the conduction system in the operating room before the surgery. And that's including another part of our team, Rena, the EP team or electrophysiology team. Chris is very correct in saying that really the decision to go to from a repair to a replacement really has to be extraordinarily individualized. And we take into account not just the anatomic underpinnings of it, but we also take into account important psychosocial factors that may also interplay with this decision making. And so but again, the importance is to involve our whole team and to individualize the care for each patient.
Another question that came up, thank you, Dr. Marks. Another question that came up kind of along the lines of making these patient-specific decisions. How often would you say, I guess, Dr. Baird, this question would be for you, that you go into the OR planning for valve repair and you end up having to do a replacement?
I would say that's extremely rare. But as a surgeon, we always have to have a backup plan. So when we talk to a family, we're generally pretty confident on our abilities and when and if we can repair a valve. But we'll always have a backup, and that always includes a replacement. And because there's so many replacement options depending on the valve, we have to have that plan and discussion ahead of time because there are differences in that. But if we're going in for repair and that's the plan and we're confident about it, probably 98% of the time we come out with a repair. There's very few situations that we don't, that we at least haven't talked to the family about it and say, look, we're going to try a repair, but there's a good chance we're going to have to replace it. I don't really count that because I think that we were concerned about it and the chances we might have to replace it are pretty good. If I tell you that I think there's a really good chance of repair and I think that's what will happen, then probably 98+% of the time, that's what happens.
Thank you. I think we have time for maybe just one more question. There are two questions, I think, in the chat about whether we can, if a patient has a bicuspid aortic valve, if that is eligible to you could do a repair on that valve, or whether the only option is to replace that. So
yeah, I think this question, for me, if it's truly a bicuspid valve, and I think there's some misunderstanding out here in the world, you have unicuspid valves, bicuspid valves, tricuspid valves, quadricuspid valves. And if it's truly a bicuspid valve, those are actually probably a little bit better repair candidates than unicuspid valves. The problem is that probably 90% of our patients that are said to have bicuspid valves actually have unicuspid valves. But nonetheless, I think the point is, if you're a young patient between 5 and 15 years old, and you're said to have a bicuspid valve, nowadays we're repairing 95+% of those patients.
Yeah, and again, the importance of this is the mathematical modeling and the precise measurements that are made. And so we even have a term called bicuspidization of a valve, where we try to simulate a well-functioning valve. So again, it really comes down to not the type of valve, but really what we see when we carefully examine the valve.
Now, I know that we're running a bit over time, but I did want to mention just to our hosts in the Benderson Family Heart Center, a lot of questions have come up about contact information, how patients and families can send their child's information to us to review. So I'm wondering if someone in the Benderson Family Heart Center can disseminate that information after.
Yeah, let me
after
just
this
comment.
webinar.
Let me just comment on that. We have a very robust second opinion program. And if nothing else, you can email, call Dr. Marks or myself, and it can be that simple. On the other hand, online, there's a second opinion referral, and there's a process there, and it's very well streamlined. And we have coordinators now that once you do that, will communicate with us and will coordinate getting us the information you already have. And then we can make a review, and we'll be happy to call or communicate with you and give you our opinions to help in the process of deciding whether surgery is right for your child, at least in our experience, and whether you would like to come to Boston to have that. So I think it's simply put, you can email me, and I put it in the streamline, and we get that information with our coordinators. You can email Dr. Marks, he'll do the same as a start, or any surgeon for that matter. And we'll make that opinion, and we'll get back to you.
And I hope everybody on this webinar recognizes just how special that is, that, you know, Dr. Baird is on here telling you, just reach out to him. And he will, review your child's information. And I think that's that he's like that, and Dr. Marks that, and all of us is one of the things that, beyond all the technology, I think is really what makes our program special here at Boston Children's Hospital. So I know I'm starting to get some reminders that we should wrap up. There will be a recap information sent out after this webinar, and in those recap materials, they will provide the contact information for second opinions. There were also several questions, about heart valve replacement in pregnancy, questions about partial heart transplant. We don't have time to get to those today, but perhaps I'll just send it out into the ethers. Maybe those are some good topics of conversation for future webinars. So thank you everybody for joining us. This webinar is recorded and will be provided to all of you and posted on the Facebook site. And thank you so much for your attention and for joining us. And thank you to my co-panelists as well.